Thanks, Ross. It hasn't escaped my attention. It's only me that's between you and dinner this evening. I'm going to talk about a topic. Well, first of all, I have no financial disclosures relevant to this particular presentation. My major goal here today is to highlight issues in the creation of a differential diagnosis for viral encephalitis. I'm not going to be showing you an algorithm. No such algorithm exists. That could be actually a fortunate thing in this day and age. But I want to talk about what are the important both neuropathological and clinical findings to bring together in coming to a differential diagnosis for a fairly difficult entity of viral encephalitis. And I also hope to comment a little bit about the strengths and weaknesses of next generation sequencing as they are in 2021. I think we're going to see a lot of improvements in that, but we have a ways to go. So I thought what I would do is just start with a case study to put it in reference. This case was a 3-week-old infant that died at home after a brief illness. It was the product of an uncomplicated pregnancy. The infant left the hospital at 3 days. Everyone at home was in their, quote, usual state of health, some with respiratory and GI symptoms, but no one severely ill. 3 days before death, the infant was cranky, poor feeding, was provided with some Tylenol with some relief, and mother put to bed the child, and in the morning just basically found dead in bed, and the paramedics were unable to resuscitate that child. Since it was a sudden and unexpected death, they obviously went to the medical examiner who performed the autopsy and didn't find anything grossly abnormal in the autopsy, although the brain was quite heavy at 500 grams and was quite readily discerned as swollen, a little bit of subarachnoid hemorrhage. And this is the H&E stained section of the brain, and looking at the cortex. So where to begin when a case comes like this? This is basically what the neuropathologist will frequently receive. Now you might think that viral encephalitides are so uncommon that they're not worth really focusing too much on, but there are about 250,000 that occur per year of hospitalizations for diagnosis of encephalitis. And the etiology is known in less than half, and it's actually known in quite a bit less than half. And so the neuropathologist doesn't see the half that get diagnosed clinically, those that are made either on clinical exam or CSF analysis. We get the ones that are left over, the ones that are really quite difficult. And so one of the first things I want to emphasize in this talk is that as the focused neuropathologist, what you don't want to do is overpromise in terms of what you're going to be able to do in terms of making a diagnosis. The case is usually presented to us, is this viral encephalitis? And it's either an autopsy or a biopsy specimen. And on one plane, you might think that, well, if it's an autopsy specimen, I've got more tissue to work with, more ability to look for different features in it. Maybe it's going to be easier. But a biopsy obviously is being done on a living patient where you still have some clinical testing that can be done, and in particular, analysis of the CSF. I think gathering CSF at autopsy is a great idea, but frequently not done. And so sometimes it's easier to make the diagnosis on a biopsy than it is an autopsy specimen. So there's hundreds of known possible infections caused by viruses, and the first thing you might think is there's got to be an application for this, and something that can run through that algorithm. And I want to assure you there isn't, and that you need to sort of use your diagnostic acumen to really make a significant approach to it. So what are the key clinical data? A lot of it is just simply available from the history and physical, and it needs to be incorporated whenever looking at the particular specimen. Obviously, the age of the individual is one of the first parameters that's going to determine early in the branching logic. Is it an infant, child, adult, elderly? They all get different types of infection based upon that age group. Most importantly in the clinical exam is any other site involved. It's very uncommon for an infection to purely involve the central nervous system. The brain is encased in a calvarium that prevents any sort of direct introduction of an infectious organism, particularly viruses, and so looking for GI or respiratory symptoms in the individual is crucial in the beginning of the analysis. Now, there's all sorts of types of immunosuppression, and they all are attributed to different predispositions to infection, and so just the general term immunosuppression isn't enough. You have to know, is this iatrogenic immunosuppression? Is it a specific monoclonal antibody the individual is being suppressed on? Has there been CAR T therapy or whatever? But these are all going to impact the differential. Vaccinations, that really works reasonably well with the pediatric population, but probably most of the people in the audience don't remember what they were vaccinated to, so it's less helpful in the adult population. Season obviously determines what's circulating in the environment, and different infections are going to be higher on the differential based upon the season. Location of the globe, of course, most of the areas where these viruses are circulating at different times are going to determine this exposure of the individual host. Physical and neurological exam is going to be important. If there's a rash, obviously, that suggests some sort of a viremia type of approach. But if there's a focality to the exam, that can also be helpful in honing down the differential. So all of these history and physical are crucial in terms of early on getting a handle on what type of virus might be involved in the pathogenesis. Now, usually the clinician has made the distinction between meningitis and encephalitis, and obviously these different symptomatologies indicate a level of severity of involvement of the nervous system, but they're all sort of key in terms of identifying what we're dealing with in terms of potential of the type of virus, but it's not that helpful because many of the viruses tend to be either global or multicentric. Now, there are exceptions to that. The herpes viruses, both herpes simplex and HHV6, have a temporal limbic localization. You're all familiar with PML being in the white matter. The problem with that is that in addition to viruses being in the differential diagnosis in many of these cases, post-infectious lesions, which can look a lot like PML, can also be considered in clinical situations where white matter appears to be the principal focus. A lot of viruses are neurotropic in the true sense of that word, and consequently can be focused on gray matter. Now, enhancement is kind of a negative feature. That is, if there is enhancement, that tends not to be in the cases of many of the viruses. There are exceptions to that, like herpes simplex, which can enhance with breakdown of the blood-brain barrier. But enhancement can try to hone the differential away from viruses and more towards other more aggressive pathogenic organisms. We're blessed with the ability to sample cerebral spinal fluid, and that has both positive and negative attributes in the viral infection category. Pressure is elevated in many meningitides and encephalitides, so that's not too helpful. But the number of cells, and the important thing is that sign there, which is less than 250 cells per mil. If there's more than 250 cells per mil, then it's probably not a virus. You're probably dealing with a different type of infectious agent, and that's also true with protein levels. If the protein is above 150 milligrams per deciliter, then you're talking about probably a different type of infection and not a viral infection. Glucose tends to be maintained with most viral, both meningitises and encephalitises, and therefore if that's depressed again, it makes you look elsewhere for causative organisms. CSF is always a day late in terms of helping with the diagnosis. Plasma serology is great if you have paired samples, but usually you're brought to the table and grilled way before those paired samples are available. So important studies to do, particularly if in cases where a diagnosis is not found on pathology, but not very helpful for the neuropathologist under the gun of the clinicians and wanting to know the diagnosis. Now, there's been a fair amount of interest in looking at cytokine profiles as another way of identifying both viruses versus non-viruses, but also individual viruses. And Dr. Mark Curtis has made some presentations at the AANP in previous meetings about this, and it's an area where there's a lot of development, and it may suggest that maybe the immune system can help focus us on a particular infectious agent. Now, about 6-7 years ago, the FDA approved this multiplex PCR, which is very helpful. It has these 7 viruses in it, and it's a test that's available from a variety of institutions. And it does collect quite a few of the viral infections. And usually this test is done, whether it's in the EMR or not is variable, but it sort of helps early on if you're dealing with a complex case. So it's important to create that early clinical differential, and it should be able to exclude most non-viral infectious etiologies based upon those CSF findings and other attributes of the clinical presentation. Unfortunately, it's not going to exclude non-infectious etiologies. The autoimmune etiologies can masquerade as viral infections, and they won't be excluded by much of that clinical data. When all else fails, that's when the biopsy occurs, and that's when the neuropathologist gets involved. But having all of that as background data certainly helps begin the equation. So what is your responsibilities as a neuropathologist? What are you supposed to define? And they're fairly simple issues. I mean, you want to know, in the case of autopsies, you want a microscopic description of all the different regions that are potentially involved that might not have been illuminated by any of the clinical studies. You can pretty much identify global versus focal, multifocal type of disease, gray matter versus white matter. That should all be an early assessment done by the autopsy pathology. Now, telling what cell type is affected or infected is a little bit more problematic. Sometimes, of course, microglial nodules center around individual neurons. Other times the nodules, such as an HIV, are obviously perivascular and unrelated to a specific cell infected. But in terms of getting a hint as to what type of virus to begin to focus on and perhaps do selective studies for, identifying the global distribution of the virus and what type of cells are infected is important in directing that study. Vascular, non-vascular focus doesn't help a heck of a lot. Necrotic infections tend to be limited to certain viruses such as herpes simplex and not characteristic of others. You can characterize the quality of the inflammation, and certainly the first stain to do is a CD3 stain to identify the distribution of mononuclear elements in the brain tissue, and sometimes a CD8 versus a CD4 is helpful. CD8 being more common in both entero and arboviral type of infections, CD4 more on the herpes type of infections, but that really isn't that strong an indicator. Now, of course, if you have inclusions and in particular cells, that not only tells you what cell's infected, but also gives you a hint as to the type of virus. How about electron microscopy? That's certainly something that I started my career on, and it was an important technique before we had any of these new molecular approaches. But really right now, I don't recommend it for much in terms of clinical assessment. It's still a very important research technique and is very important when one is reporting cases. But if it's not biopsy material, the autopsy material preservation seldom permits identification of virion structure. So biopsies, if appropriately fixed, can be used. But of course, when you look at a biopsy, you're looking at somewhere between 20 and 50 cells on a thick section. And your ability to detect viral particles is obviously not very sensitive. When the particles are present and you see nice icosahedrons like you're seeing here inside a nucleus, that's very helpful for identifying herpes virus type particles. So you do have some specificity associated with the EM technique, even though there's limited sensitivity. But you can also get examples like this, where there's kind of novel toroidal inclusions of viruses that we found in a retina, and I still don't have an idea about what virus that is. So it can be a blessing, but it's not very helpful in terms of diagnostics. So you can go into differential based upon purely the pattern that you elucidate through the autopsy. If it's an infection that seems to be purely limited to the meninges, even though the clinical scenario might have been less clear, the types of viruses that are involved there is more limited and can focus your subsequent specific studies. If gray matter is involved, enteroviruses and arboviruses are much higher on the list. White matter, obviously, more likely involved with the JC virus. But again, masquerading with some autoimmune types of infections is important and going to be important in making the distinction. Panencephalitises can be more evident with a herpes or arboviral type infection. So if you're just trying to get a 95% chance and you have lots of time and lots of antibodies, you could just simply start picking off this group that's listed here. This will pretty much gather many of the viruses that you can detect on either biopsy or autopsy, but you're frequently going to come up empty-handed with this. And again, you get back to there's got to be an application for this. Well, there's now the famous, what I call a Hail Mary pass, which is metagenomic next-generation sequencing. And there's lots of papers out about this. They're relatively small studies. It's pretty much in its infancy, but it has great promise in terms of helping us make a diagnosis about specific etiologic agents. The process is pretty straightforward and simple, and I'm sure you're all familiar with it. You just simply extract all the nucleic acid from the specimen, create a library of that, do some informatics analysis with base recognition, quality control. It's important to remove all sort of human host sequences and then just compare it against the database and identify the species. So in theory, it sounds like there's no need for a neuropathologist at all. Just simply send the nucleic acid. The problem is it doesn't work out that simple. I've had almost no success with sending out specimens for metagenomic next-gen sequencing. The first problem is that the specimens that we have in front of us at the time that we're trying to make the diagnosis is usually a formalin-fixed paraffin-embedded specimen, which has degraded nucleic acids, which is fine for many of the techniques that we apply, such as in situ hybridization, but is abysmal in terms of metagenomic sequencing. Again, if we had cerebral spinal fluid, that can be quite helpful, but most viruses in the CSF are at very low copy numbers. And so the focused PCR tests that we're more familiar with can pick up those low copy numbers and identify specific agents, but some of the metagenomic amplification doesn't allow that same sort of level of sensitivity. The specimen of cerebral spinal fluid has to be depleted of either human or bacterial genetic material if you're looking for a virus. And if the CSF has greater than 200 cells per mil, one is the thought is it's probably not a virus, but it's also true that the next-gen sequencing doesn't work well on it. It's hard to separate out the non-viral sequences. So it's important to realize that the usual technique that we use for PCRing up low-level copies, which is what we're going to expect in the CSF, something on the order of like 100 copies per mil, is going to be positive with a targeted PCR, but it may not come up positive on a metagenomic survey. Now, the good news, though, about metagenomic analysis is that if there is something else in there, and it isn't a virus, the unexpected pathogens can be identified. So while I think metagenomic analysis in CSF has a ways to go still, it is offering something in the future for viral infections, but even in the present for unexpected infections. Well, does it matter? And unfortunately, that's a question that frequently comes up because how can we treat viral infections? And the reality is that there's actually more and more therapies becoming available. I just listed a dozen or so of the more common viruses that can be detected and the types of therapies that are of some utility, different for different viruses in the treatment. So it does indeed matter if a virus is there, what type of treatment can be proposed. But perhaps even more importantly is that if it's not a viral infection, and there are all sorts of agents listed on the right there that can masquerade as a viral infection, and they are all amenable to effective therapy. So it's important not to give up when facing a complex clinical situation, but to gather the clinical data and to put together that along with the pathological findings and come up with a reasonable differential. It's not going to be an algorithm that comes up with a final diagnosis, but it should come reasonably close. And is it important? Well, a lot of cases get diagnosed as viral encephalitis and treated as a herpes simplex encephalitis. And many times, in 10% of the cases that were reported in some of the studies, a different virus was found or a different treatable entity. So it's important, there are therapies, and it's important not to give up. So let's take a look back at the case that we started with in the infant who died of unexpectedly, and this was our H&E stain section. The first thing that I do when looking at this is get an idea about what level of this cellularity is the developing nervous system versus an immune inflammatory response. Obviously, in this H&E stain slide, there's something going on in the meninges, but less obviously something going on in the central nervous system tissue itself. And the easiest way to do this is just simply a CD3 stain. So that's sort of an initial way to begin to get an idea is it a meningitis, is it an encephalitis, is it an encephalitis that is multifocal or global, is to do the CD3 stain on autopsies on multiple sections and biopsies on the specimen that we have. So additionally, it's important in the case, even though you may only have the brain tissue for analysis, in this case, to check with the medical examiner and find out was there any pathology anywhere else. And in this case, they generously offered us to look at the tissue ourselves. And on the left, you have an H&E stain section of the heart of an infant, which clearly shows edema and changes there. But it isn't until the CD3 stain is done that you can really identify that, yeah, indeed, there was more than just the brain involvement, but in fact, this was an example of a meningoencephalomyocarditis. So putting together those simple findings on neuropathology along with the histology helps us kind of hone down to a diagnosis and begin to sort of focus in an economical way how we can further work it up. So we know based upon the constellation of organs that are involved, both the heart and the brain, that could be a viral etiology. The child had no evidence of in utero involvement, had been born well, there weren't any inclusions, we weren't thinking in terms of herpes. The good thing about infants is they're like adults during COVID. You don't get around very much. You just sort of hang out at home. And so it's not very likely that they're going to get exposed to arboviruses or some other agents. But respiratory and GI illnesses are common at home, and they can be the sort of principal focus. So the top suspects in a case like this would be this could be an enterovirus with less likely an adenovirus. So the next study, well, we have the tissue in paraffin. We can use antibodies that are targeting individual viruses, which would be quite costly and painful. But there are, of course, antibodies that cross-react with numerous agents in individual families. And since we're into enteroviruses, in this particular case, we used an antibody that cross-react with lots of known human enteroviruses. And you can see on the left in the heart and on the right in the brain that this antibody is clearly identifying infected myocardial cells in addition to neurons. So we know it's an enterovirus at this particular juncture. Now, if you run a research lab and have the ability to make lots of radioactive probes, in this case S35 labeled probes, you can stain the heart, again on the left and on the right, with specific probes. But that's not the usual technology that's available to all of us. And instead, we can use more generalized chromogenic probes that are available to identify initially initially general sequences of enteroviruses and then specific viruses, which in this case was a Coxsackie virus. So we have two technologies, immunohistochemistry, which we're familiar with and have used for the last few decades, and it has strengths in that the lab's familiar with it and the chromogenic probes are readily available. Unfortunately, it has lots of problems in that there are fixation artifacts, and the biggest problem is antibody variability and antibody availability and lot variability. So we've gone away from using immunohistochemistry and moved over towards the in situ hybridization. You don't need the radioactive probes. The chromogenic probes are adequately sensitive for it. And more importantly, the design of the chromogenic probes allows for both specific and sensitive detection of viral agents. But again, without the clinical scenario helping focus on individual studies, this would also be an expensive way to get to an individual diagnosis. Cost really depends upon how well you've honed that differential right from the beginning. So what's the point? Well, that's the point in Pittsburgh, but the point in the talk is not to panic, not to give up on the particular specimen. There's no specific algorithm. This is really going to be a systematic approach where if the clinical data, both laboratory, history, physical, can be brought together, a specific focus study will essentially render a diagnosis. Thank you. Doug.
Clayton, thanks for that. And, from my readings, I haven't used it myself, metagenomic sequencing can also turn up viruses that are not necessarily pathogens. Would you comment on that?
Yeah, like tobacco mosaic virus and things like that, which we know aren't there. So even if the metagenomic analysis comes up with something, it has to make practical and logical sense. Yeah, you can get misdirected on that. Yeah, they're picking up sequences. Yep.
Yeah, thank you for this great presentation. So my question is, when you feel comfortable ruling out viral infection, so I'll give a scenario. When you have a biopsy of a white matter where there's a lot of inflammation around the blood vessels with CD3, and it does look like infectious. However, the clinicians did everything and excluded all the possible infectious agents, and it doesn't look like the other differential, which is demyelinating or autoimmune or vasculitis. So when we feel comfortable saying, okay, now I have all this information from your side, I will be comfortable to say it's not viral or not infectious, and you can go ahead and treat with immune suppression therapy.
Okay, just to be sure I understand the question. So you get a biopsy and it's got white matter and it's got inflammation in there, and there's no real hint as to a potential agent. And your question is, when do you say, well, I don't know whether it's post-infectious encephalomyelitis type of phenomena with demyelination versus a virus? Am I understanding your question correctly?
Yeah, so the pathology does not look like, it does look like infectious and does not support demyelinating or vasculitis for all the pathologists who saw the case. However, all infectious agents done by and it was extensive, done by the clinician were negative. And then, so of course we put that report with a long comment and that we cannot exclude anything. Then the clinician will not be happy because he wants to use immunosuppressive therapy from his side. But with that report, he couldn't, saying, okay, we cannot rule out infectious agent. Even we did the metagenomics and it showed nothing. So the question is, when really should be comfortable saying, okay, I have all this information from your side, I will say it is not. It doesn't look like infectious.
Right.
We cannot say that at all.
Yeah, it's a balanced clinical judgment at that juncture. So, and I want to go back to one of those very first slides I had. Again, don't overpromise in terms of where you're going to get with the neuropathology. However, you as a neuropathologist are bringing additional testing to the table and the diagnosis. So what your scenario is a complicated clinical situation, and this is a frequent one, where there is this an infectious etiology, or is this an autoimmune-based etiology, and then you have to look at it. And in the case of white matter lesions, basically the idea is, look, is it demyelinating? Because if it's not demyelinating, then a potential infectious agent is higher on the list. But if you're seeing, clear myelin vacuoles, preservation of neurons, and that type of thing, that's not what you see in a typical viral infection. Right.
Thank you very much. A practical question. So if you get a small biopsy in this kind of scenario, the frozens, and the surgeon wants a frozen and it's never diagnostic, can we just say, let's save this? Do I have to leave my office? Or can I just tell them, really this is an extensive workup and we should save the tissue?
Yeah.
So what's the utility of frozen in these settings?
Right. It's the same scenario that we all experience, whether it's with infections or with tumors. It's the please don't make me use this entire specimen and have nothing left to do any of the studies that I just showed a few moments ago. In infectious etiologies, we do our best to talk them out of doing it. There's nothing that we're going to be able to tell intraoperatively. Maybe there'll be a day then you might get an inclusion that you could see in the infection. It does happen, but it's much better to preserve the material. So yeah, talk them out of it. Right.
Great. Thank you. Can I ask, there's one question from there's a number of questions and compliments for such a clear and systematic approach to these cases and your reasonable approach of managing expectations. One question is, what about using fresh or frozen tissues for metagenomic analysis?
Yeah, so that's certainly an option. It gets back to Eddie's question right at the beginning. You've got your core biopsy, and now you're going to split it. And the part that you ship off for the metagenomic analysis, you don't know, of course, whether it was exactly the same as the other. If the lesion is big enough and both cores are representative, you can get that. Certainly, it's available. I haven't myself ever availed myself of it because I've never had the preservation of the material. Was always biased towards getting the formalin-fixed tissue. So they would get around the formalin fragmentation of the nucleic acid, and that would be very helpful. But then they still have the problem of separating it out from the host and other genomic material that they have in order to make that diagnosis.
Great.
Has anyone had any success with frozen tissue in metagenomic analysis? Yeah, I haven't seen it reported.
Great, thank you.